I'm Dave Casper. Welcome to another edition of Inclusive Magazine. Our guest today is one of the few people in implant dentistry that literally needs no introduction. Please welcome Dr. Carl Misch. Carl, thanks for being here today.
Hello, Dave. Good to see you again.
Good to see you, my friend.
Yeah.
So we're here in Las Vegas, the AAID annual conference. You gave an outstanding lecture yesterday on immediate implant placement. Probably 1,000 people in the room, standing ovation, and a Lifetime Achievement Award.
Yes.
I can't imagine that's your first one, but it was nice to see you up there.
It was nice to receive the award and, of course, the invitation to be here and share my experiences with the group at large.
It's a great meeting so far. But I want to start really from the beginning and go all the way back, and that is the decision to go to dental school. You graduated University of Detroit,
Right.
1973. So what made you decide to go to dental school? And I can't imagine there was any implant exposure in that program back then.
Well, actually there was. Let's start with why I went to University of Detroit. It's because I lived in Detroit. And
it's good enough reason.
I was the first one in my family that went to college, so that my dad was a bricklayer. And I can remember when I was about 5 years old, playing outside, to kick the can, all the kids used to play, and an ice cream truck would come down the road, and we'd all run and get some money for an ice cream. And I went in running to my dad, and he was working at his desk, looking at some blueprints, bidding on a job, because he owned a construction company, and like I said, he's a bricklayer. So I said, Dad, can I have some money for an ice cream? He said, no. And I remember being shocked at that. And I stopped and I looked at him and I said, what job do I need that I never have to ask you for money again?
Wow.
And he looked at me kind of shocked and he said, a dentist or an attorney? I had no idea what an attorney was. I had some teeth taken out. I knew what a dentist was. So I said, I'm going to be a dentist. And of course, when you're growing up, everybody always asks young kids growing up, what are you going to be when you grow up?
Right.
You know, they expect to say fireman or whatever.
Right.
And I said, I'm a dentist. And after saying that for like 10 years, I said, why not? You know, and then I was lucky enough to get sports scholarships into college because my family couldn't afford it. I got married when I was only 18, and so I had to provide for a wife and a kid, and I didn't have any money to go to college, but I was good in sports. I played football and baseball and diving and wrestling, and I ended up getting a baseball scholarship to University of Detroit.
Wow.
And so I played baseball for them, was captain of the team for a couple of years, set quite a few hitting records. So then I got invited to spring training by the same scout that drafted Al Kaline, who was the hero in our town at that time. And at spring training, I found out that once you get into the minor league system, only 5% ever make it to the pros even one day.
Wow.
I thought once you were in minor leagues, you were
So
just
automatic.
the next step. And when I heard 1 out of 20 go on from here, I'm married, I have a kid, and I had gotten accepted to dental school. And so I said, well, if I go to dental school, I'm going to make a living, you know. But so that's why I chose dentistry. And because I had a wife and kid, and captain of a team and college team in baseball, the other students in that freshman dental class elected me president of their class. And we had a new
Because you seemed
team.
responsible, I'm sure, by comparison.
Yeah, well, I had to be responsible. You know, you got a little kid and a wife. And because of the sports scholarship, that added a little bit of flavor to the mix, I guess.
Yeah.
And we had a brand new dean, and I took the role on as president of the class like a union leader. So if we had more than one test in one day, I'd go to the teachers to negotiate to spread it out. You know, if we had any notes from the previous class, I would copy them, make sure everybody in the class had it. At the end of the year, we'd look at the points, the clinic points people have, and if a few of us had many more clinic points than others, we'd share them so that we'd get through as a class. And so as a consequence of that commitment of sharing, and that we're doing this as a team, not as individuals. Instead of competing with each other, we started supporting each other, and they ended up electing me every year president. And then I became president of student body, and we had this new dean come in, and because I was this union leader, I found out that he had a PhD in histology and anatomy. He was a periodontist, and I went to the library and pulled out any publications he had, and he had published a couple papers with a guy named Bodine, who was one of the original people from Loma Linda that did subperiosteal implants, and Clyde Mohammed did the histology on these subperiosteal implants, human histology, first time it was ever reported. And so I read his papers, and when I met the dean, of course he says, "Why'd you become a dentist?" And I said, "Well, I became a dentist to learn about implants." He says, "Oh, I've written some papers on it." "Oh, you did? Oh, yeah, well." He says, "Well, let me restructure your education so that when you take anatomy, I'll restructure it so it'll be related to implants. And when you take histology, I'll share with you the histology I've done on implants." And,
wow.
And as a consequence, I started this implant training my first year of dental school. And then just by chance, there was a guy at our school that would give an hour lecture a year. His name's Paul Mentag. And Paul is one of the original founders of the AAID.
Right.
And he would give an hour lecture on implants. And he brought in a guest clinician. And the first time this guy ever did a hands-on surgery at a university was in my dental school. And because I was president of the class, I was the assistant because I knew where the gauze was and all this stuff. And his name is Leonard Linkow.
Wow.
So I met Lenny from that experience. And so I started doing implants my senior year in dental school. I was done with my requirements. I had applied for a couple patents already by the time I was a senior. And there was a international congress in Monte Carlo. And my dean sent me to Monte Carlo. He says, "I don't know what to do with you. You've taken everything here. You're done with your requirements. There's this implant congress in Monte Carlo. Would you like to go?" And it's great. So he pays for my way with my wife. And I'm lecturing out there. And in the audience is Ken Judy. And, you know, it's just funny how these very early, just by chance experiences.
Casual introductions.
Yeah.
Did you know Ken at that time or no?
No. I saw him first. I knew him by the literature, you know, but I had never met him before.
Wow. Yeah. So you graduate, you go into private practice for a while?
Well, I started doing implants immediately because I just always thought it was part of dentistry. You know, I was probably too bold and stupid to realize that it wasn't part of regular dentistry. And because I was magna cum laude and had some decent hand skills, and dentistry came very easy to me. Most anything I saw, I thought I was qualified to do.
Even if you hadn't done it before?
Even if I hadn't done it before, because after all, we had lectures on it, and so, you know, the lectures for clinical lectures, kind of like similar to the lectures of histology or anatomy, and so you're expected to know it, and I would know it, and I had, by that point, I had developed this photographic memory, so I could just regurgitate just about anything that I've read. And so I'm thankful now that I didn't have a patient get a heart infection after an extraction, because I probably would have tried to replace the valve, because we had lectures on valve replacement of hearts. I mean, as a dentist, you get lectures like in everything in medicine, you know?
Yeah, why not try?
I didn't know my limitations at that point. But I knew that I needed more education. And so in order to get that, what I would do is I'd set aside about $60,000 a year, and I would have a patient that, for example, needed a subperiosteal implant, and the guy that was modifying the designs and doing the most research at the time was Bob James. So I would fly to California. We would do the surgery together. I'd fly back with the patient, and so I would see the healing, I'd remove the sutures, and I'd do the prostheses. And then I started doing that with endosteal implants with Linkow, and then I started doing with Tatum. I did a hip graft with Tatum. I did, you know, other procedures with Tatum. I flew patients to Europe and did things with Hans Groffelman. And by the end of 5-10 years, the major people in the field, I had been in their office. I had done surgery with them. They knew who I was. I'm providing them patients.
Yeah.
And so
quite popular, I'm sure, as a result.
It opened up a lot of doors for me.
Yeah, I bet.
And as a consequence, it was an accelerated hands-on learning experience, which really we have in developing a specialty. You know, I never realized how important it is, the specialty training that we get in dentistry. As a general dentist, I had this implant-restricted practice. I would do full mouth rehabilitation routinely. And I could never understand why going back to school to do 3 or 4 supervised cases makes you a specialist, and better if you're, I'm already doing 100 cases, you know.
So when you graduated as a general dentist and went into private practice, your practice from the beginning was limited to implantology?
Yeah.
So you didn't have the first implant case jitters, you just dove right into the deep end of the pool.
Well, I didn't know any better, you know. I mean, stupid confidence, you know. I hope I've replaced it with quiet confidence. But I just felt that this was the right thing to do. And these removable restorations, I didn't have anybody that was happy with them.
Yeah.
And the more I read the literature, the more I was aware of what was happening. And it just made sense to replace teeth with teeth.
And a lot of subs, blades?
I did quite a few. The most common patients I had referred to me were lower denture wearers because the profession didn't know what to do with them. And so if somebody had a lower denture and was complaining, go see Misch. We don't know what to do with you. And the second most common referral I
don't think that's ever changed, right, after all these years.
Yeah. Second most common patient I would see is somebody missing one front tooth because the patient didn't want to cut down 2 adjacent teeth and lute them together. And so I don't want you touching these other teeth. They're in good shape.
They're fine.
Go see Misch, you know. And so the 2 patients I would see most often would be a single tooth implant in the aesthetic zone or a mandibular full arch case.
Yeah. So you're in practice for about 10 years, and something happens where you decide, I am going to go back to school, do a cross program.
Well, I was flying out to help Bob James develop a specialty of implant dentistry. And in fact, the first application I wrote myself. The EAD wasn't willing to support it back then, so I had the ICOI support it because Kent Judy was a closer friend. And so we submitted that first application. There were 5 steps to get through to be a specialty, and we got through one of the steps.
This is a recognized specialty with the ADA?
Yeah, with the American Dental Association. And so then Bob became president of AAID, and he's picked up the banner of the specialty. And so because I was flying out there and helping with this program out there, and he had the first university-based implant program. And so we started using University of Loma Linda as a base for the specialty in the area. And we got through another step of the specialty when I was with him. And then a guy named Ishmael asked me to develop a similar implant program at Pittsburgh. And he was the head of a prosthetic program at Pittsburgh. He says, will you come to Pittsburgh to develop a program like you did with Bob James? And I said, well, he says, well, I'll tell you what, if you're willing to do that, I'll get you a specialty in prosthetics. Now, being stupid at that point, I thought he was just going to give me a specialty, hand it to me. You know? So I go there and I spend 3-4 years. I developed this 3-year program, and I'm expecting to get my master's in specialty. And he says, no, you got to go to school. You got to be here full time. You got to do this clinical work. I said, you lousy bait and switch guy. I was so mad with him. So I ended up flying out to Pittsburgh every week. I'd stay 3 days there and fly home, and then, you know, on the weekend I'd be lecturing someplace. But I ended up taking every course and every clinical thing, and took 3 years because I was doing it part time, 3.5 years.
Wow!
But I eventually got my master's and specialty in prosthetics.
Was that awkward being in some of those classes with an instructor looking over your shoulder and maybe you know what he's teaching you?
It was interesting in that, you know, they would say things like an oral path. This occurs 6% of the time. And I'd say, wait a minute, I've been in private practice for 7 years. I haven't seen this once. How can you be telling us it's happening 6% of the time? So I was a major pain to them. So,
I'm sensing a trend.
Yeah. But I certainly did learn the science of dentistry, you know, because I had this experience before I went back for the specialty, that I could take the biologic sciences and the clinical sciences and pick out what made sense and what I would see most often, and developed a role of dentistry based on science rather than dentists. Basically, I trained like my dad was trained as a bricklayer. You watch and you do, and you don't understand the chemistry of mortar and the differences in setting time by
but
temperature.
You know it works.
But you know it works, and you copy it, and that's basically how we're taught as dentists is do this because I told you to do this. You don't know why, but all I know is if I do this 6 times, I'm going to get out. I get my check off, and I'm going to get out. You don't, and so we lose what makes us a doctor. We're really, we don't like to be called tooth carpenters, but the reality, a carpenter's better trained than we are. They have an understanding of why they make a bevel or how they treat wood differently,
right,
if it's a different type of wood. And a dentist that's why it's so easy to fool a dentist, is they're just show me, and they think by seeing it or hearing about it that they're able to do it. And I was there myself. But it'd be like watching somebody play the piano. You can't go home and play the piano. You can see the world's best pianist 100 times, but you go home, you can't play the piano.
Can't duplicate that effort.
And there's this hands-on requirement with supervised training to allow you to accelerate your understanding and learning curve to it, and that's why I developed the Institute, because it allowed me to have a supervised hands-on training in this field, which we never had before. And I realized when I went back for my prosthetic specialty that what made me better as a restoring dentist wasn't that I did another 60 cases those 3 or 4 years. It's that they were supervised and they were criticized and every step was evaluated, and you're reading the literature every week and you're being questioned on it and you're talking about it and you're thinking about it, and you spend 3-4 years doing nothing but concentrating effort on one small aspect of dentistry. And at the end, instead of doing 100 cases, which are really one case 100 times, and you're doing the same thing over and over, you're getting faster, but you're not getting better. The specialty allows you to understand why you're doing it. And indeed, you're getting better. And we really do need a specialty of implant dentistry, because what I see in the field is just based on what's faster, easier, simpler, based nothing on longevity or reducing complications or the other aspects of it. And to me, the title doctor means more than being a tooth carpenter.
So you mentioned the Institute, Carl, and at 1984 seems like about the same time the Pittsburgh experience was ending, or was there a light bulb moment that made you decide, I'm going to take on more responsibility, more work, and build this institute?
The reason why the Institute started when it did is that the concept was developed in 1984. Prior to that, I was flying to Pittsburgh and developing this specialty program out there, and on occasion flying less often to California, but still continue to help Bob with that program out there. And I never took a practice management course in my life because finances weren't a problem for my practice. There were no other implant dentists. I was a crazy guy from Dearborn, and that people knew where to send a patient if they couldn't handle what was going on. But I was the go-to guy if there was a complication at the dental school and they ended up losing their teeth. Go see Misch, and he'll replace. If they're getting sued, I'd put them back the hole. So I became the go-to guy if you were having a problem, type of thing. But I never really looked at building a practice or implant practice because I was getting referrals because I didn't have any competition, basically, back then. And I took this practice management course, and they gave a homework assignment to these 25, 30 doctors that took this thing. And they said, you all are different specialties. It was run by a pedodontist. And they all had different specialties that were in this course. They weren't general dentists primarily. And they said, whatever your interest is or your specialty is, come up with a way to develop something that your field needs. And so because I was traveling around the world carrying patients with me to do this supervised training by the world's authorities.
The $60,000 a year.
The $60,000
budget.
a year budget. I said, well, what if instead of me flying there, I have them fly to me and I supervise their surgery, and they fly in with their patient, we do a surgery, then the patient flies back with them. And so the first institute, there were 5 sessions, came up with that same week, and you would bring a patient for each session, and then we would do the surgery together. And then I got permission from the state board to have all these doctors without state licenses come in and have this supervised training aspect of it. And that was never done before in dentistry, in any aspect of dentistry. There was never any supervised clinical cutting of teeth or surgery, so it was the first hands-on supervised course outside of specialty. And because the need was so great, it was fairly easy to enroll the program. In fact, the other 25 people that were in that class, when I came up with the idea the next day, and report your homework assignment, the instructor said, "Are you willing to do that? You're really willing to do this?" And I said, "Yeah." He says, "Well, how long would it take you?" I said, "Well, at least 5 3-day weekends." I know dentists want to be there Friday, Saturday, Sunday. They don't want to come during the week.
No.
So to this day, it's still 5 3-day weekends.
Did you know the answer, or you just had to give an answer?
I had to give an answer. But when you're doing it for a living for several years, you got an idea,
True.
And so I had no idea what to charge. I'm not an economic guy at all. And so the instructor said, "We'll charge $15,000. To me, that was a lot of money, because continuing education courses were like $100 or something for a weekend, All of a sudden, $15,000. I'm thinking to myself, nobody's going to sign up for this. Everybody in the room said, "If you want to do that, I sign up." So the first institute class were the guys that took that practice management course with me.
Sold out.
It was sold
marketing.
out immediately. No marketing. I had the first. Now all of a sudden, I had to come up with 15 days of lecture. The longest lecture in implant dentistry back then was an hour. There were a handful of guys that had maybe a 3-hour lecture, but it was basically some cases that they showed, and they'd always show the same cases over and over again, the same story, same joke, there wasn't any education. It was just, here's a couple cases that I've done, and it's always the best case that they've got pictures of.
No complications ever.
No continuity of why they did it, or no case series studies of what are your complications or what's your evaluation. So all of a sudden I've got to come up with all this lecture material, because I have to come up with 15 days of lecture instead of a 1 hour.
And at this point, were you thinking that you personally were going to be responsible for that level of content, or did you have a faculty in mind?
I started inviting some faculty in to help me with the surgeries, because all of a sudden we were doing 20 surgeries in a weekend.
Right.
Well,
you need help.
I needed help, and we were starting 7 o'clock in the morning, and I'd be there till midnight.
Right.
And so it just, when somebody's on an early learning curve during a surgery, they take 4, 5, 6 hours sometimes. I mean, they take forever.
Yeah.
So I needed some help. So one of the early guys that I brought in was Jack Hahn. Another early guy I brought in was Ken Judy.
Right.
And they would help me with the surgeries. And then, of course, my residents that I had selected for the full-time residents for the implant program. So one resident was Craig, my brother. He was my associate, and he was doing implants as my associate, and then he enrolled in my program so he could get the university specialty or certificate implants. And Randy Resnick, and so they came in and started supervising. It was good for them, because now they're teaching it, so they were learning faster.
Right.
And most of those people are still with me. I mean, we've been around since '84, and most of the faculty are still there. So it's been an interesting road.
Is it still $15,000?
It's still the same price, $15,000, 15 days, 5 3-day sessions.
So you're saying a pedodontist and a homework assignment.
That's right.
Led to over 10,000 dentists being trained through the Misch Institute.
That's right.
Unbelievable. Now, but that curriculum, as I understand it, is the implant curriculum for 5 or 6 dental schools today.
6 dental schools use the Institute for their oral implant education for their specialty. So what they find is, if they're teaching perio especially, that they don't have any faculty to teach implants because they're periodontists. Yeah. They're good at root planing, scaling, or whatever they're doing, but they don't have any specialty level of knowledge in implants, and so they take a weekend course, and they come back and they regurgitate what they heard that weekend, but they've never done the procedure themselves. In fact, most of the specialty programs, I don't want to talk too much out of school, but most of the specialty programs, what I've seen is
the director of 125,000 dentists watching. Don't worry.
The directors of the program have their residents take pictures of their surgery, and they have to give the director the pictures so the director can grade you on your, and then they have all the pictures of their resident surgery, and then when they give a lecture, they're using the pictures from their resident surgery, and they've never done the procedure themselves. And so a lot of these authorities have never done the procedure they're lecturing on. Mm-hmm. And so I
think that still exists today.
Yeah, well, not as much, I hope.
Maybe not in a university setting, but certainly some implant programs.
Yeah. So if, what the hope is that the specialty programs that decide to incorporate implants in their specialty, which a lot of them have, prosthetics just did it this last month. They changed the definition to include implant surgery.
Fantastic.
Perio has done it, oral surgery has done it. And as a consequence, since they don't have any faculty for it, they meet with me and they say, can we send our residents to your program? And it really started with Pittsburgh, but then it went to University of Detroit, and now there's 6 different dental schools that I get their perio residents or their oral surgery residents, and they come through the institute, they get university credit for it, and they get their implant training through my institute. And 6 different dental schools do that now.
That's fantastic.
Yeah.
Well, what about at the undergraduate level for the general dentist? You had some exposure because you had a dean who was passionate about it.
Yeah.
In Detroit, but the typical dental school today, the typical dental student today.
Well, it's evolving. It's not as quickly as I would hope, but I give a lecture that has become very popular on the longevity of 3-unit bridge and its complications compared to a single tooth implant and its complications. And
right.
And within that, it's becoming more and more people are becoming aware that you do a better service to the patient if you replace the tooth with an implant rather than cutting down the adjacent teeth. And 1 out of 4 bridges end up decaying. And it ends up being one of the major causes of loss of teeth, of additional loss of teeth, is doing a 3-unit bridge instead of a single tooth implant. So not only does the device last longer than the 3-unit bridge, but the adjacent teeth last longer. And in fact, when you're doing this 3-unit bridge, it starts a cascade of destruction of the rest of the mouth because the pontic of a bridge acts as a plaque trap. And you can't effectively clean the pontic. And less than 8% of our patients floss on a daily basis. In fact, a survey I'm doing right now, less than 8% of the dentists I train floss on a regular basis. And as a consequence, 1 out of 4 of these bridges eventually decay. And now that word is out, and I've published it in Dentistry Today and in all my books, and I lecture 50 times a year since 1984. So I'm on the road constantly. And so the word is getting out that an implant is better than a bridge. And as a consequence, a number of dental schools have started replacing the requirement to do a 3-unit bridge to a 3-unit bridge or an implant.
Oh, okay.
And indeed, we've got a couple studies done of which senior dental students doing single tooth implants have high success rates, and as a consequence, in fact, at Tufts, it was 100% success for 5 years. They didn't lose 1 implant for a 5-year period for senior dental students doing this thing. And let's face it, drilling a round hole with a round drill and obturating the hole with an implant is easier than doing endo. In fact, I call it a root canal and bone. Every dentist has to do a root canal, and the roots are dilacerated, and accessory canals are coming in there, and you're dealing with infected pulps. With an implant, you got healthy bone. You're drilling a round hole that's straight, and you're obturating instead of warm gutta percha, trying to fill this thing out 3-dimensionally. You obturate it by threading in some piece of metal. I mean, if a carpenter can do this, one of my best friends is a carpenter. And when I went to Nicaragua to volunteer after the earthquake to help them down there, I brought him with me. And he says, you're gone every weekend lecturing around the world. He says, show me some cases of what you do. So with great pride, I show him these implant surgeries, and he goes, You're just putting a screw in. I do that 1,000 times a day. I'm a carpenter, you know. In his eyes, it was the same. And
Right.
there's a lot of similarity to it.
That's probably true.
Yeah.
He can't charge as much for putting in those screws.
Well, he can, but he wouldn't be very busy. Yeah.
In 2007, you published an article that talked about the need for more general dentists to get involved
absolutely.
in placing implants. And
It's been my observation that one of the reasons why the implant field wasn't growing as rapid as it should is that unfortunately, the economics of dentistry, you do a 300 bridge, you can schedule your first opening, you get all the money, you deliver the case a couple weeks later.
Right.
You do an implant, you send it off to somebody else, you don't see it for 6 months, and you're doing 1 crown instead of charging for 1 crown instead of 3 crowns. And so economically, it doesn't make sense to a general dentist to do the implant crown. Economically, it makes sense for him to do the implant surgery and crown, because then it makes sense and does put his time into that effort.
Right.
And so approaching it one by which is a better service to the patient, that's the way I try to go first. I try to be a moral compass to the profession. What should you do if the world is watching you? Not what can you do, what should you do? And, you know, can you rob a bank for a living? Well, you can, but you shouldn't, you know. And so within that moral compass, I was trying to get them to come into the implant world because it was better for their patient, but it wasn't enough felt need for them. So then when we got to the general dentist doing the surgery, all of a sudden, it was much easier for them to start incorporating implants within their practice and doing it routinely.
And that's, you think, more because the economics, at least, were equivalent to a true implant.
Unfortunately, that's the economics has something to do with it. It should just because do what's best. You wear the title of doctor, do what's best. It's part of my lecture, but the reality is you want it to grow faster, you're going to make more money doing it, you're going to get more people doing it.
Yeah. It makes sense. Another thing in that article that struck me as interesting was you talk about the importance of having a great team, which almost seems counterintuitive as the general message is the dentist should do the surgery and the prosthetics.
You know, as dentists, we're taught to be competitors with each other. We compete with each other in class for grades. We compete with each other for grades in clinic. We compete for patients within the dental school. We're competitors. The dentist everybody likes is a dentist that comes to the meetings, that can't pay the bills, that doesn't have any money, is crying in the corner. You know,
because at least I'm better than that guy.
I'm better than that guy.
Right.
You know, but we're really taught to be competitors, and as a consequence, and we're also taught that there's everything can be done better. I've never seen a perfect crown. I've never seen a perfect, you know. In fact, we openly criticize each other because that's the way we're trained. We do this work, and the professor comes in and openly criticizes us in front of the patient, in front of everybody else, and you know they make us in this inferiority complex that we can't do it very well. We're always criticized, and I explain to the residents, you know, have you ever seen a perfect mouth? And the answer is no. There's always something wrong with it, which means we could have a class action suit against God. He's never done it right once. You know, well, obviously our definition of what is right may be wrong. Right. So I try to put it in perspective of this moral compass aspect of education for dentistry at large and implants specifically. And the Institute, because I'm allowed to have these people spend 3 days with me at a time for 5 consecutive times, within that year, they've modified the way that they look at a patient. They've not modified the thinking process for what should be done and what's predictable. And as a consequence, you can always tell a Misch implant trained doctor. You know, the things that I hear constantly is they typically know more than the guy lecturing at the podium, and they have an awareness, a confidence that what they're doing is the right thing. So the team approach, getting back to that aspect of it, is so important to be able to do that. But we're not taught a team approach as dentists. Physicians work on patients as a team. If I'm a general surgeon, I can't do a surgery on a patient until that patient has gone to the internist and had a medical clearance of systemic conditions at large before I can do surgery. So they're taught to work within colleagues of different specialties, and they're constantly referring back to each other, and they don't criticize each other's work. They understand that they're on this team to help this patient, and within whatever their specialty is, they participate in that treatment. And as general dentists, rarely do they send out patients. I mean, general dentists send out less perio than almost anybody else because they do it themselves or the patient doesn't get it. They send out less oral surgery because they take out the tooth themselves or the patient doesn't get the service. And yet the best way to treat a patient is a team approach in most any specialty. And the only person on a team that should have no experience is the patient. You don't want the patient with a lot of experience because that means they've had a lot of complications. This is probably not the place to start.
You definitely refer that patient.
But the team in implant dentistry is a pretty broad team. For example, if you're going to do sinus grafts, your team should include an ear, nose, throat person. There's occasionally you're going to have a patient that you need to get an evaluation of the sinus before you start manipulating the membrane, or if you have a complication afterwards, patient needs to be admitted in the hospital, have somebody on your team you already know and you work with. And so have somebody to send your complications to. And yet we're not taught that as dentists. We're attempting to do everything ourselves. And the team in implant dentistry includes your assistants, your front desk. So when a patient calls up, ask about an implant, they're not giving this baloney answer.
Right.
You know, I will often, when I return a phone call of a doctor, I'll pretend I'm a patient, and I'll say, you know, something like, you know, I'm Mr. Smith, I'm here at the airport. I was supposed to be picked up according to Dr. Monroe, and I've got my $100,000, and he told me I could have it done today. And it's just to pull their chain, see what they would do, you know. And, oh, wait a minute, I'll go get it to the doctor.
That's horrible.
And so, and I'll ask them questions like, well, what is an implant? And I had one staff member say, well, we take out teeth and we put them in the refrigerator and we find a tooth of your size and color and we put it in your mouth. So
no.
Really. So you have no idea what your staff is saying unless they're on a team and they've been trained. So we started training staffs at the Institute. And, of course, the laboratory is a major member of the team. Glidewell, the thing that you guys have been in education for a long time. I've lectured for Glidewell a couple times in my career. And I've noticed that the lab has an attention to detail, that they have a commitment to the doctors that they work with. And you need to have a laboratory, if you're going to do implant prosthetics, that does these cases all the time. Because any laboratory that gets involved in implant prosthetics, they start to realize this is not the same thing as working on teeth. You know, the dentist working on a tooth isn't going to take off more than 2 millimeters of structure because they're going to run into the pulp. And so you get a preparation that more or less looks like the tooth that's going to be finished plus 2 millimeters added to the contour.
Right.
The implant is put at any angle, and the post is at any angle, and you're in embrasures, and you're too facial, and you've got this inventive prosthetics constantly in the implant world. And if the laboratory isn't experienced, and they're learning on every case, it becomes a nightmare. It becomes a nightmare for everybody. So, as a consequence, you need to have specific training for crown contour, for occlusion, and that requires a laboratory that financially has invested in implant education.
True.
Yeah.
True. Dr. Misch, in 2008 you published a paper on, it was a landmark paper, 10-year survival report on posterior single unit implants.
That's correct.
And I think the success rate was just short of 99%.
That's right.
So why isn't every general dentist doing this? You touched on the economic factor earlier, but with evidence like that, and now it's nearly 10 years after that paper was published.
Well, I mean, part of it is man sees what man knows. They're not aware of the differences. Their instructors are given the same course that they've given for the last 10 years, and they haven't increased their education relative to it. So if you look at, you know, a general dentist education, they're getting the same lectures that the last 10 years general dentists have gotten. And the world of implants consumed the field so rapidly that the use of it, for those of us that use implants, was more rapid than the education. And as a consequence, not only the doctors, but also the instructors, they're always looking for the fastest, easiest way to do something because they have no experience, and so they want something easy. I don't want to study for 2 years before I do an implant. I'll take a 1-hour course, and and that's why these things like the pin implants or the things that are perceived as easy become so attractive because, oh, I don't have to reflect the tissue and I don't have to numb the patient up, and
Right.
they're always looking for a technique, a sinus graft. Well, I'm going to drill below it and just pound it up because I saw somebody do that and they said it worked, and so they'll attempt to do that. It's kind of like doing surgery with your eyes closed. I mean, it can be done, but you're not going to be as predictable. And so as a concept then, since we don't have enough supervised learning courses, we're always looking for something that fits within our comfort. And we attempt to modify things almost immediately based on no experience, but our comfort zone. I don't know how many people I've trained, for example, if I'm going to do a posterior sinus graft. You make a window that's about 10 millimeters by 15 millimeters, but that looks like a big window to them. So they'll make a little 3 millimeter diameter window thinking, well, it's less intrusive.
Right.
Yeah, but you can't manipulate through that little hole. You can't. You end up tearing the mucosa. You end up, the procedure doesn't work. And then they say, oh, that doesn't work. I tried that. That doesn't work.
Yeah.
So, there's a learning curve to this field, and you need to have somebody that's taught it before, that has a history of teaching it. And with the 10,000 people that have gone through the Institute, one of the things that constantly we find out is that the people that I train have higher success rates than the literature. If you do a review of the literature, they'll say, well, this procedure is 80% successful, and then you take a Misch Institute trained people, and the success rates are twice that, so it's like a failure rate of 5% instead of 20%. And it's because I teach not what I can do, I teach what you can do and what type of case you need to start with. And the Institute is designed so that each institute talks about a different area of the mouth, so you learn about the anatomy of the anterior mandible, including the bleeding problems that you can have associated with it. Then another weekend we're talking about the posterior mandible and what's unique to that area. Another session is a posterior maxilla, what's unique to that area. And so by the time you get through these 5 3-day weekends, you've looked at all the areas of the mouth with different types of prostheses that we talk about with each one. And by the time you're done with the program, you can put the pieces together to come out with something that is a logical based conclusion based on the science of clinical studies. And it's really the only program that's designed like that. I mean, the only separating thing that determines an implant candidate in most beginning practices in implants is the patient says yes. If the patient says yes, you're doing it, regardless of the training you've had or anything else. And so probably the only thing that saves the patient is it's so expensive, most say no.
Saves the doctor.
And so, but eventually you start getting some experience level doing it that way, but it takes years, and you have a lot of dead soldiers along the way. So the organized program that I've developed that keeps the patient, protects the patient, protects the prostheses, protects the laboratory, because when you have a failure, everybody on that team suffers.
Yes.
You don't want to pay the lab bill, or you're redoing the case, and you'll say, look, and I'm not charging the patient because I'm redoing this for nothing. You're not going to charge me a lab bill, are you? Root Lab once did a report, and he looked at how often does the doctor ask him to eat the lab bill because he's redoing the case. And it was like 38% of the time. It was a big number. And, so it affects all the members of the team. And all of a sudden, everybody is, I'm losing money on the case, so I'm going to try a faster, easier way over here. I'll put in fewer implants, and I'll put them in immediately, and forget about the angle. The lab will figure it out. If you look at the complications in implant dentistry, the vast majority of them are related to biomechanics. And yet, as a dentist, you have no classes in biomechanics. And the reason why we get fooled so easily on implant number or position or angulation is that we have no background in biomechanics. We go through our program, and we learn about bacteria. And the majority of our degree, we might as well say we don't have a doctorate of surgery. We have a doctorate of biologic sciences. We have a doctorate of histology, pharmacology, oral pathology. Everything we learn is related to biologic sciences. And as a consequence, we get into the implant world and we think what's most important is the bacteria or these biologic sciences because it's important with teeth. Therefore, an implant's like a tooth. Turns out the vast majority of the complications are biomechanics. And we don't have any training in biomechanics except in orthodontics. For every action, there's a reaction. So you get you get moment forces to rotate teeth. But we don't have any understanding of biomechanics. And the thing that made the Institute so different is that early in my career, Jack Lemons asked me to develop a program that gave a master's to PhD degree in dental implant engineering at the University of Alabama. And so my residents would be doing all these studies based on biomechanics and implant dentistry. And as a consequence, the complications that we have is far fewer than any other training session because we understand the science of abutment screw loosening. We understand the science of prosthetic screw loosening. We understand the science of occlusion and porcelain fracture. And I've had to modify most everything in prosthetics in order to fit the science of what we do.
And even today, the majority of the publications, some of the stuff we heard yesterday from the podium, biology.
Yeah.
And you were really the first person, and it's led to at least 24 concepts that are now standard, I would say, in how every patient is treated, whether it's a bone density classification or bone height and width classification. But why is biomechanics still, why hasn't that become the center of attention? Is it just harder to grasp?
It is.
Is it back to how it's taught?
What I believe is because we don't have any basic understanding of biomechanics as a profession at large. And we have this. We wear glasses of bacteria. You ask a dentist, what's the #1 cause of loss of teeth? Most of them say periodontal disease, where it's not periodontal disease.
Overload.
When it comes to a 300 bridge, it's number 8 on the list. It's not #1 on the list. It's, So if we look at the concept of biomechanics, I guess dentists, because they don't have any courses in it outside of ortho, that they kind of go blank. And as an educator, I don't care what field you teach in, if you use a word that the audience doesn't understand, the learning process just stops, and they're trying to assimilate other experiences to try to figure out what you said, or they forget the concept completely. And when you get into moment forces and strain and modulus of elasticity, all of a sudden you start seeing people's eyes glass. It's not a familiar world you're into.
Yeah.
And so they're always looking for these biologic answers. The most common reason for crestal bone loss or an implant, you ask a periodontist, well, it's bacteria. Because with a tooth, it's bacteria. Therefore, with an implant, it's bacteria.
It must be.
But it's not bacteria. It's biomechanics. It's a strain of a bone cell. And yet most dentists are unaware that a strain of a bone cell is important for maintenance of the bone volume or its strength. And the bone cell is very much like a muscle. You break an arm, you put a cast on, and by the time you take the cast off in 6 weeks, the arm is smaller in size. Well, the muscles have atrophied in 6 weeks because they weren't used. But if you look at the bone mass, it's also less. That bone needs to be stimulated to be maintained. And as a consequence, one of the things we emphasize at the Institute is these 2 implant overdentures are ridiculous. People lose bone 4 times faster in the back of the mouth than the front of the mouth. You're putting a couple implants in to help maintain the bone where it already is, and they're losing the bone in the posterior 4 times faster. And the posterior is the area that causes paresthesias and fractures and things like that. And if anything, you do a 2 implant overdenture, you accelerate the posterior bone loss. You accelerate their major complication. And this doesn't make sense. I mean, it's like as a dentist, you go in there and you seed a rough area with some bacteria. I mean, basically, we're become part of the problem rather than part of the solution. And once you get through the science and understand why we treat patients a certain way, instead of doing 2 implant overdentures, most of your cases will end up being 5, 7 implants and a fixed restoration because I can stop the posterior bone loss if I unload the posterior bone in the area. And so it's good for your practice because instead of doing 2 implants, you're doing 7. It's good for the laboratory because instead of doing an overdenture, they're doing a 14 and a bridge.
Right.
You know, and it's based on what you should do. You know?
Doing what's right.
It goes back to doing what's right.
Yeah. You've taken these biomechanic principles in the mid-late 90s, I believe, with the introduction of the Maestro system.
Yeah.
And what were you thinking? I mean, what were you thinking that was missing in the dental implant space at the time that you wanted to get involved in the commercial side of the business?
Well, I didn't have any desire to get in the commercial side of the business. I mean, in retrospect, maybe I should have held majority of the stock. Because it certainly would have been an easier life to be like Niznik and sit in the commercial aspect of it and smile every time you buy an implant. But I didn't want to lose my clinical practice. I mean, basically, I'm an implant dentist, and I treat 60 patients a year that almost nobody else can handle, and I take a lot of pride in that. And the research we do is trying to elevate the standard of care. And the very first mission statement that I wrote for the Institute back in 1984 was to develop a program that would help set and elevate the standard of care in implant dentistry. And whenever I get lost, you go back to that mission statement, and it kind of puts you back on track. You know, it is like taking a sail ship and correcting it for where you're trying to go, and the winds come in, and you have to correct it. And so I developed a mission statement for my private practice that I want to help my patients maintain their teeth and/or implants the rest of their life. Well, once you design a mission statement like that, I say, what are the most common reasons why people will lose a tooth? And I list the most common reasons, and all of a sudden, if you got one of those reasons, we're going to fix that because these are one of the reasons why you'll lose additional teeth or complicate what your implants are. And all of a sudden, the patient understands why they need something done. The patient understands why a tooth should be replaced, or the patient understands why you're probing next to the tooth. And if the probing depth gets beyond 6-7 millimeters, the bacteria changes and you increase the risk of bone loss. But it starts by a mission statement. And that mission statement really does put you back on track of why you're doing a certain entity relative to that. And it applies to a practice, and it applies to my institute. Probably applies to your life.
Yeah, it certainly does. You think back to the introduction of the Maestro system, there's probably 6 or 7 implants on the market. None of those implants are on the market today. Let's talk about that. It wasn't that long ago, and now today there's 100 implant systems on the market. Do we really need that many implant systems? No one knows implant design better than you. What's your take on all this craziness?
Well, you know, when a new implant gets on the market, I asked the guy who developed it, you know, what was your intent with this design? What I hear most often is that the guy or the team that developed the implant, they have a central mission statement for their design. Often it's ease of surgery. I'm going to design something that makes it easier to do the surgery so that they, from their own experience or people they hear, well, this looks too complicated, so I'm going to reduce the number of steps, or I'm going to make it easier you don't have to pre-tap the bone with this system because it taps it at the same time or whatever. But the implant is designed to be easier to place surgically. Because of my interaction with the engineering school, our concept was, let's design an implant that'll lose less bone. If you look at the history of implant dentistry, the first implant out there talking about bone loss was the implants that I was designing because it was based on the strain of bone. We measured down to the angstrom level of bone cell movement, how to maintain bone to be lamellar bone rather than woven bone. Woven bone is weaker than lamellar bone. And based on that modulus elasticity of bone versus titanium, we came up with general principles that a design should have. For example, bone is much stronger to compressive load than to shear load. If you look at materials in general, porcelain, it breaks easier with a shear load. It's strongest to compressive load. Well, it turns out bone's the same thing. You put a compressive load on bone, it's 60% stronger than if you put a shear load on it. So what implant designs put a shear load on bone? V-shaped threads. V-shaped threads put a shear on the bone. That's why they're called a fixture. When Brennemark used the word fixture, that's an engineering term. It's used to fixate metal to metal. And what it does is this shear load that's applied to the metal interface stretches the metal within this modular elasticity so the screw comes loose less often. But that shear load is not good for bone. Bone is strongest to compressive loads. And so that's why we got rid of the V-shaped thread and put in the square thread. Now the disadvantage of that, the square thread is harder to place surgically. I mean, instead of something that will cut the bone and be easier to place, well, the square thread, you may need a tap. And if you're in hard bone, it's harder to place. So it's like, the saying, everybody wants to go to heaven, nobody wants to die. So that's why I go back to what is the intent of the developer. Our intent was to maintain bone, the strength of the bone, long term for the life of the patient. If it was for surgical ease, it wouldn't be a square thread. It'd be a tapered implant. Tapered implants have less surface area than parallel wall implants. But a tapered implant is easier to prepare the bone. It's easier to put it in the top of the osteotomy. It's easy. If you're having an implant rodeo, you can put more implants in if they're tapered than if they're parallel wall.
Well, you do cylinders then.
So, or cylinders, right. So it gets back to what is the mission statement of this design. And I understand that the ones that are easier to place are really attractive because there's not only a perceived learning curve, there is a learning curve on it.
Right.
And certain aspects of an implant design make that learning curve a little more difficult. After 10, 15 implants, well, then
it's less important.
Yeah, it's less important. Yeah.
Let's talk a little bit about something that you've spoken out on previously, and that's the all-on-4 treatment protocol.
Sure.
You've been critical in its use in a widespread, or I'd say maybe a more universal application of an edentulous patient. Talk to us about your feelings on that.
Well, I mean, if it comes back, if we know that the majority of complications in implant dentistry are based on biomechanics, and whether it's bone loss, abutment screw loosening, prostheses fracture, uncemented restorations, if you list all the complications that you see in an implant practice from once the implant heals to after it's loaded with the prostheses and the next 5 to 10 years, the majority of the complications are related to biomechanics. Wound healing is very predictable for the body. 7 million years we've had teeth, and the body's learned how to heal a socket and taking a spear out, the wound heals. And so basically I'll tell the residents, if the patient doesn't die in the next 3 to 4 months, they'll heal. The patient's going to die or heal, and they heal. So wound healing for the body, the biologic science of wound healing, is the surgery application of what we do. But once the body heals, the thing that maintains what's going on is more related to biomechanics. And in its simplest form, one of the easiest things for dentists to understand is stress equals force divided by area. The higher the force, the higher the stress, the greater the area, the lower the stress. So your intuition knows that. Nobody puts one implant in and puts 14 teeth on one implant. That's not enough. Why? Because there'll be too much force and too much stress, then the implant would fail. So as soon as the guy puts in a second implant, he already has proven to me he understands biomechanics. Okay? Because if it was based on just bacteria, you put it in the front, you only have one thing to clean instead of 4. It's right in the front of the mouth, so it's easier to get to than putting them all over the place. So if bacteria was the only thing you had to worry about in the hygiene, just put one right here.
Right.
But as soon as you put a second one in, biomechanics is important. Now we can discuss how important do you think it is,
right,
and what do our studies show. So because stress equals force divided by area, 4 implants instead of 6 would have higher stress. All on 4 means none on 3. We had a series of clinical studies with 3 implants in Europe. It become really popular, the Innovum system, and they reduced the implant number to 3 because they used to put the prostheses in at the same time, and the fewer the components, the easier the things fit. And the more implants you had, the harder it was to put in the pre-made prostheses, so they reduced the implant number to 3. And I can remember going to Europe. I used to have a practice in Monte Carlo, so I used to be in Europe every month. And I would see lectures all over Europe about this all-on-3 Novum system. It was one of the most popular things out there. Fewer implants, less costs, do it all at once, immediate load. I mean, everybody's talking about how great this is. 3 years later, not one guy is talking about it.
Gone.
I mean, if he even mentioned it, people go, boo, you know, really a big backlash for them.
Yeah.
And as a consequence, you know, the all-on-4 concept can be used. I'm not saying that if it always failed, you'd be pretty stupid to do it. We'd all know this from now. The fact is that it works sometimes. So where does it work? Bone is good. The forces are less. Where are the forces less? Upper denture, has the natural teeth, female, preferably old and rich, you know, has less force than a young male. You know, so I go through, you know, both my book and the Institute, 5 patient force factors relative to how much is the force part of the equation. And then you get into the area part of the equation. How do you affect the area? A number of implants is the greatest way to affect area. Secondary ways, well, the diameter of the implant number is much better than diameter, but it's part of the equation.
It could help.
You know, the length of the implant, well, it's part of area, but it's not as important as diameter. So there's an order of importance relative to it. And part of it is, what is the strength of the bone? Every carpenter knows that the strength of the wood they build a structure with is part of the equation. If you ask your carpenter patient, you know, I went to the lumber yard and they had a sale on balsa wood, so I'm going to build my house out of balsa wood. Carpenter will look at you and go, doctor, don't build your house out of balsa wood. It's too weak. Your house will fall down. Yeah, but it's on sale, you know. Doc, don't use balsa wood. Now, what are you going to do in my mouth, Doc? Well, where your bone is soft, I'm going to put in fewer implants. See, I mean, we know less than the carpenter. The guy didn't graduate from high school. He knows don't build a thing out of balsa wood, you know. But the dentist, the ones that call doctor, they think that it's not even part of the equation.
Interesting.
You know, it doesn't even it would never make sense to any carpenter. It only makes sense to a dentist because they think it's the bacteria. See? And the bacteria isn't affected by the strength of the bone. Bacteria is not affected by the bone density. So the only one that believes that shit is a dentist, in my opinion.
Carl.
Sorry, David.
You mentioned your book earlier. Your first book, Contemporary Implant Dentistry, it's now in its 3rd edition, I believe, and widely, unavoidably, the most popular book in all of dentistry. So first of all, congratulations on that.
Thank you.
But we were just talking about all-on-4. Think about today, some of the treatment protocols we have today. What else has differed from the first publication of that book? How has how you treat patients evolved through the different editions?
Surprisingly, there's very little in the book that I've had to come out and say this was wrong. Okay, there's other ways to get to the top of the mountain, what we know now. So there isn't just one way to get to the top of a mountain. There's several pathways. What we've learned is some are easier pathways, some are more complicated. But what is the pathway that's most predictable for an early learning curve? And that's the things that I try to emphasize within the Institute is I'm not going to show you everything that can be done. I'm not going to show you everything that I can do. I'm going to show you at your level the most predictable pathway is along this road. And that's what the concept is developed around. And so if I look at, I'm working on my 5th book now. If I look at the last surgical book compared to the first surgical book, the first surgical book was a formula based on the majority of the time this is the way you're going to do it. Okay.
Okay.
As our knowledge expanded, as our studies expanded, then we looked at, okay, this is how you modify based on what the strength of the bone is. This is how you modify it based on the patient desires. This is how you modify the basic concept. If you look at the basic concept, for example, Nobel is where most of us started. As far as a basic concept, Nobel treated completely edentulous patients. They had no studies on overdentures. They basically had treatment planning was one chapter. You put 4 or 6 implants in the front of the jaws, and you screw in some teeth that go to the back of the jaws. And for those of us that were Brandmark training centers, of which I was one,
right,
we were taught by the Nobel PI, Brandmark primarily, that once the implant was integrated, it was there for life, and that you didn't hear about complications relative to prosthetics or things. You could cantilever back to the spine, is what we were told. Now, when we started trying to redo those studies here in the American system, we found out real quick you can't cantilever back to the spine on every case. You can on some, okay? If you've got enough implants in the front and the back, you can get, you know, but if you try to do the same Brandmark protocol, you didn't get the same results.
Right.
And I can remember meeting with PI one time, and I'm saying, you know, we're having trouble duplicating what you guys did here in Sweden. And and so, for example, the things they started doing, I feel, at this point, are hedges on the dishonest. The vast majority of people, for example, don't realize that the 81 paper that everybody quotes, or the original studies of Brandmark. Let's talk about bone loss. Bone loss was measured from the first thread. They justify it saying, well, everybody knows you lose bone in the first thread, so we'll call the first thread 0.0. The first thread is actually 3.3 millimeters below the crest of the bone. So when they say 0 bone loss, it's really 3.3 millimeter bone loss, because if they say 6 millimeters, well, it's really 9 millimeters, because they're 0.0, they elected to be at the first thread. They elected to determine integration radiographically. If they didn't see a radiolucency around the implant was osseointegrated. There was no clinical evaluation of rigid fixation. It was a radiographic evaluation.
Not even the mirror tap.
No, or tapping, the Swedish ring, of which we showed you the ring would sound the same if there was 1 millimeter bone around it or 16 millimeters of bone around it, If there were no probing depths relative to the original studies. It was purely a survival study based on x-rays, and if a patient lost an implant that wasn't loaded for a first year, the patient was taking it from the study.
Didn't count.
So the implants weren't included in the system until they had been successfully loaded for a year, which means they were successfully healed. So implant that was lost in the healing stage was taken out of the study. If they were lost during the first 6 months of the study, they got to be loaded for a year without complication. Now they're added to the study. And people just don't know that. So what they're showing is, okay, the best cases after a year, those are the ones that are included in this study. And that's why we could never duplicate what they were doing, because you
counted everything.
Yeah, I mean, people did not read the beginning of the paper, I guess.
Yeah, we always go to
as far as the criteria. So they looked at the table for success, which really wasn't success because they didn't have a criteria for success. The criteria for success, it's in the mouth.
Right.
And if it's in the mouth, well, it's successful. And so it's these survival studies, and 88% in one jaw and 90% in another jaw, but you have no idea how many.
Yeah.
It's shocking. It's shocking how misleading the original research was. And Bob James and I wrote an editorial and pointed out some of these things, and we were almost castrated from the profession. I mean, everybody was so upset.
How dare you?
They had no idea how they were being misled, but they didn't like the whistleblower. So Bob and I suffered a little bit from that editorial. You can remember that.
Thinking back to the first edition of your book, one of the more dominant themes throughout it on the prosthetic side is a early passion that you had is early loading, progressive loading of prostheses. And yet today, and we heard it this morning even from the podium, it seems like if the implant is in at X number of Newton centimeters, you fill in the number, go ahead and load go ahead and load the implant. That seems to be the prevalent thinking today. So
it was said by one dominant clinician, and everybody copied it. But that same dominant clinician is the one that said infiltrate, and the patient will tell you when to stop, and you drill right through the nerve. That same clinician has said a lot of things based on carpentry, but not based on any studies or based on any science. And an implant, Newton centimeter load that an implant can take is more related to the density of bone and the implant design than anything else. It's not related, can you immediate load or not? It's not related to the bone implant contact. It's not related to, it's related to, if you have a tapered implant, you can get more fixation quicker than a parallel wall, because a parallel wall doesn't get that torque until the very last turn
to the bottom
in the area. And so, to me, the Newton centimeter, maybe it was a way to sell a handpiece that gave you a higher Newton centimeter so you can evaluate it. So you have to buy a special handpiece to evaluate that aspect of it. But what it does from a science aspect is if the bone is real soft, the implant will strip the interface. And if the bone is firm enough, it can resist the torque that's placed on the implant. So what you're really evaluating is what is the bone quality of the implant. However, if I change the design, I can dramatically modify what the Newton centimeter would be. For example, if I made it a cylinder, well, none of them are going to resist that aspect of it. If I decrease the thread depth, none of them are going to resist that aspect of it. So it's related to what is the design of the implant and what is the strength of the bone. It has nothing to do with can I immediate load it or not from a science aspect.
Yeah, so how do you teach at the Institute today? It does seem like there's this rush to get the case restored, and maybe that's patient-driven as much as it is fewer appointments in the chair.
Well, it's some of it is patient-driven, but it's been my experience that the ones that are most in a hurry are those that are older. And that's probably a benefit for this, because the older patient has a slower cellular turnover rate, so they don't go through as fast a woven bone interface when the implant is loaded. So that kind of protects the patient a little bit because of the age. Because I haven't had younger patients really talk about how fast can I get it done. You get somebody that's 90 years old and they say, I'm going to die in a year. I don't want to wait a year to be done in this thing. I'm not building this for my coffin, you know. So they're the only ones that I've really seen that kind of push the time element on it. But in my practice, when I charge for a case, I charge for the case, and then I charge a risk factor. And if I'm doing a procedure that has a higher risk associated with it, I charge for that. I charge more for that procedure because I have a higher chance that I'm going to end up having to do something else. And it's been my experience, once you put your hands on the patient, they want you to treat them for free until you're done, at least until they get their first set of teeth.
Right.
You know?
You own them.
And so you might as well increase the fee up front. If you know you're going to have 1 out of 4 problems with this case, increase your fee. Definitely don't decrease your fee. And if you tell the patient, look, I can do it this way, it'll take 8 months and the fee will be X. I can do it this way, which is a lot faster, but the fee will be X plus Y because there's a higher risk.
Yeah.
They don't understand higher risk because they expect you to treat them for free, whether they have the risk or not.
Right.
But if you're going to treat them for free with the higher risk, you should charge more. Now you tell them, there's a higher risk here, so I'm going to charge you more. Every patient I've explained that to, we got a higher risk, so I'm going to charge you more. They say, well, what's the difference of a couple of months? I've been without teeth for 10 years. Why do I got to be 10 years in 1 week?
Right.
You know, what's the difference here?
Another week.
You know? So it applies probably more to a patient that has to go through a something removable, and they have a fear of wearing a denture. So they're going to lose a front tooth, and they don't want this flipper in their mouth. So they've got more of an incentive to get something in there that's more fixed. But especially the all-on-4 patients, which are edentulous patients primarily, mandible or maxilla, it's a complete arch edentulous where you use this concept the most. They can cope for another month or 2 with what they've been doing. They've been wearing this for years already, most of them.
Yeah.
So
I'm glad you brought up your your philosophy on risk-based fees to patients. I've heard that lecture a couple of times, but what we're seeing a lot more of now is a direct-to-consumer advertising approach by many dentists, where they're advertising complete implant treatment and it's $995 or $2,000 or whatever the number is in the given community.
Yeah, it is true, because what they're trying to separate themselves from the other people in their community. So why should I go to you rather than the guy down the street? Because now there's so many people involved in implants that what separates you from somebody else? In the past, it used to be clinical experience, so the end result. The thing that I built my reputation on was set from my mission statement. I want to be able to create an oral environment that will allow your teeth and or implants to last the rest of your life. And as a consequence of that patient understanding that this is our mission statement, there's other ways that we can do this, but they have a higher risk associated with it. So whether they're willing to accept the risk and you're willing to reduce the fee, I mean, you can make a living in implant dentistry for almost any fee associated with it. And if you're willing to risk the risk, the failure,
accept the risk, sure.
Accept that, psychologically or medical legally in today's environment, it doesn't make sense to me. I mean, the medical legal aspect of it, just the first time you get sued, you're not going to push the case again.
Right.
So it doesn't make sense. I try to treat the patient the way I'd like to be treated myself. When I was diagnosed with my brain cancer, I was at wherever the car accident took me to the emergency room, and they do a CAT scan and they discover I have brain cancer. So the guy that's on call there says, well, you got brain cancer, you need immediate surgery, you can't fly with this thing. I've scheduled my appointments, cancel my appointments tomorrow so I can put you on the table tomorrow, and you're probably going to die on the table. 3 out of 4 people died during the surgery. And that night I'm making my will up and I'm calling the kids and they're driving down from Michigan, but I wasn't feeling too great about it, but this is the cards that I'm dealt. Well, my daughter, the next morning I'm scheduled for the surgery, of which 3 out of 4 people die during the surgery. And maybe I had a moment of clarity that night, because instead of thinking immediately what's going on, because all this stuff is coming at you immediately, I said, wait a minute, I can't by accident be in the best place in the world to have this procedure done. I know in my practice people have flown from Australia to have me work on them. I can't just by accident be in the best place in the world.
What a coincidence.
If you were going to have this procedure done, who would you have it done by? And he says, well, look, my schedule's been opened, you really can't fly, you can't travel with this condition, so he's trying to talk me into this. And I said, look, I'm not going anywhere until at least you give me one more name so I can talk to one other guy. So he gives me this name, Sylvester Comprehensive Cancer Center. And my daughter says, my girlfriend, that's his father. He donated the $300 million to build this cancer center. So she calls her girlfriend up. The girlfriend then calls her dad. The dad calls a surgeon. The surgeon says, look, I do 380 cases like this a year. He says, you will not die. I said, I like you.
Go to that guy.
You're the guy I'm going to pick. So I want the guy that builds his reputation not because he got an opening tomorrow or that it's cheaper, but who would you like to go to? And if I was the patient, I'd like to go to somebody who's going to give me the best chance to have a good outcome relative to that. And with that quiet confidence then of doing not the fastest thing, but, that's what we try to treat our patients. And that's what I try to teach within the Institute, is not what is fastest, but
what's best.
Yeah, what's
doing
best.
What's right.
What's the best chance for the best outcome, especially when your mission statement is this has got to last the life of the patient.
Yeah. Well, I can't thank you enough for being here. I really appreciate the conversation. And I know the 1,000 people that were in the audience giving you a standing ovation yesterday, the one thing on their mind was, how's Carl doing? You look great, and we look forward to many more years of your teachings.
Thank you, David.
May God bless you.
Apologize to the audience for rambling. Maybe you can cut this interview down to 5 minutes to get 5 minutes out of it.